Hello, my name is Karina, and I will be conducting a situational analysis looking at postoperative pain assessment and management. Modern research presents multiple suitable modes of effective pain relief, so the question arises, why do patients still suffer considerably with postoperative pain? This situational analysis will be looking at surgical patients as a cohort. A study by Chow revealed that 80% of patients experience acute postoperative pain. 75% of these people experience pain they classify as moderate, severe, or extreme. This is a major issue as poorly controlled pain can have significant effects on speed of recovery, wound healing, a risk of post-surgical complication, and a substantial risk of chronic pain. Reducing postoperative pain will greatly reduce the risk of these, and in turn shorten hospital stays and improve patient satisfaction. The high rates of patients still experience pain mean there is a gap between research and practice that must be bridged. This analysis will look at research revealing the best way to assess postoperative pain and the best way to manage it. It will then focus on barriers health professionals face to implement these and ways they can be overcome. Research reveals the best method of assessing pain postoperatively is a combination of the Numerical Rating Scale, NRS, and the FACES Pain Scale. The NRS is a way for patients to rate their current pain severity on a scale of 0 to 10, with 0 being no pain and 10 being the worst pain possible. This way of assessing pain is known as patient self-report. It is the most effective way to measure pain and where possible should be used. The FACES Pain Scale is where a patient points to the face that best represents how they feel in terms of pain. Research reveals placing both scales alongside each other results in the most accurate pain assessment. If someone finds the NRS difficult to understand, they can use the FACES score. This is common with younger patients or patients who have a language barrier. Scoring pain in a universal way assists the nursing staff to understand the patient's pain intensity, assisting in determining the best treatment methods. It is important to take into account a patient's level of sedation and respiratory status prior to providing any opioids, as these can cause respiratory depression. This is done by closely observing the patient postoperatively. When monitoring the patient, the nurse should be aware of any behavioral response that could be a result of pain. For example, the patient's body language. They may be grimacing or clenching their teeth, reluctant to move in bed, or taking shallow breaths. These are all important red flags that show that the patient may be experiencing pain. Furthermore, vital signs such as increased heart rate or elevated blood pressure can be a result of pain. Research has revealed regular monitoring of pain using the NRS and the FACES pain scale is the most accurate way to assess pain postoperatively. The question arises, is this being done in practice? Studies observing nursing behavior revealed that nurses often do not use this form of assessment. Instead, nurses simply ask the patient, "How is your pain?" This is a very open-ended question, where answers may be misinterpreted. The nurses believe the patients would report any pain they were experiencing independently. This is not effective, as patients are often hesitant to report pain as they don't want to be difficult or interrupt nursing staff when they are busy. They may also be reluctant to report pain as they fear the adverse effects of pain medication. In addition, nurses were often found to doubt the patient's report of their pain and rely on how the patients looked and the nurse's experience of how it usually is. This style of assessment and reporting is not following evidence-based practice and results in uncontrolled pain, which can lead to poor recovery, poor wound healing, post-surgical complication, and greatly increase the risk of chronic pain. Extensive research has been performed on the most effective form of postoperative pain management. The gold standard is a multimodal approach. This is when a combination of analgesics is used, each with a different site of action or mode. For example, combining opioid medications and non-opioid techniques such as local anesthetic techniques, paracetamol, or non-steroidal anti-inflammatory drugs. This is beneficial as it allows a lower dose of each medication to be used, particularly important for opioids. It also reduces the possible adverse reaction of all medications because the patient is receiving a lower dose of everything. One of many examples is a study by Lampert, Wagner, and Manning that analyzes the effects of multimodal analgesia on postoperative pain, adverse effects, and overall patient satisfaction following a total knee arthroscopy. The study compared patients who received a multimodal approach versus those who were on a patient-controlled analgesia alone. The patients who received the multimodal pain management had lower pain scores, used less opioids, experienced less adverse effects, and had an overall higher satisfaction level. Similar results were noted on multiple worldwide studies. If research shows that the multimodal analgesic technique is the best, then why are patients still experiencing such high levels of pain postoperatively? Studies by Duncan and Marshall presented multiple barriers to effective pain management, including failure to prescribe and administer the analgesia, pressure for early discharge, failed local or regional block, a lack of importance placed on pain management, which could be due to a lack of knowledge or education, or failure to perceive factors that increase pain after surgery, including opioid tolerance, pre-existing addiction, and pre-existing chronic pain. Furthermore, a study by Taylor and Stanbury revealed a common reason for poor pain management in postoperative care was the modern healthcare environment, including busy hospital wards, inadequate staffing, lack of timing, and a lack of importance placed on pain management. What can we as nurses do to bridge this gap between what the evidence is showing and what is being done? There are multiple articles that have researched this topic and commonly noted a need for further education. Whilst this is important and useful, to see results, more than education sessions needs to be done. Pain management must be a high priority for everyone in the surgical team, and most importantly, the patient. Patient education on pain management and assessment is an extremely important factor in improving the postoperative experience. A trial was done where patients were provided with pre-recorded tapes, including educational material on what kind of pain to expect, the use of pain medications to relieve this pain, and alternative therapies such as breathing exercises or music to distract from the pain. The patients were also reviewed daily for the first few days following surgery. Pain scores were significantly lower compared to the group without these interventions. In addition to the tapes, patients should be educated on the importance of reporting pain and the most appropriate way of describing their pain, for example, using the NRS. This education must be done prior to operation so it can be fully comprehended. Patients should also be aware of why they are being asked about their pain and the importance of being honest to achieve the best results. If a patient is aware of the negative effects of prolonged pain, they'll be more likely to share their pain and take measures to control the pain. As for the surgical team, including nurses, surgeon, and anaesthetists, a culture must be created where pain management is a high priority. Managers should keep a close eye on patient feedback concerning postoperative pain. If feedback is given where a patient reported poor pain management, all staff should be spoken to and brainstorm ways that the pain could have been managed better. By introducing policies for regular, accurate pain assessment and placing a high level of importance on individual patient experience, naturally pain will be better managed and monitored. Once nurses understand the importance of pain management, they must share this knowledge with their patients and encourage them to share any experience of pain during their hospital stay. Another important point for education is handover, particularly handover from pre-admission. This should be where patients alert staff about any opioid tolerance, chronic pain, or previous allergies that may influence the effectiveness of medications. This is extremely important as the dose or method of analgesics may vary depending on this. This point should be highlighted during handover even if the patient does not have any of the above, to ensure that it is being ticked. Postoperative pain management and assessment are extremely important. Extensive research has been conducted on both subjects and should be utilised in practice for best results. Strong patient and staff education must be enforced to create a culture change surrounding this topic. Postoperative pain can be well managed when everyone is on the same page. Thank you.